I'm just an ordinary Kenyan, an ordinary African man. In my career across the continent, I worked very closely with the government of Rwanda to design the non-communicable disease strategy, and which attracted immediate investments from the government and an international organization. So basic things that we need to understand that we require accurate data, because without data, we can't make informed decisions on how to control prevent disease. So if I were to highlight some of the moments I'm proud of, I would highlight the things that I've done that have translated into actual action, guiding policy and changing lives where it matters the most. The one thing that the world should remember about me is that I tried my best to solve some of the most pertinent problems around access to healthcare on the African continent.
Welcome to D2AFRICA Stories, the unique podcast of the scientific leadership in Africa. Here, we highlight visionary Africans who are transforming science, health, on the continent futures. We also believe that your starting point doesn't determine your destination. We celebrate those who dare to build the Africa we want, the Africa we need. I am Dr. Vincent. I am your host, and my mission is to help you thrive and transform life starting from anywhere. If you are new on our channel or on podcast, consider subscribing us for more content. Today, I have the estimate honor and pleasure to welcome someone whose work has touched millions of lives. He has helped mobilize hundreds of millions of dollars for health reform and influence national strategies and stood out at the intersection of leadership, equity, and evidence. He is a recipient of the prestigious Calestous Juma Science Leadership Fellowship from the Bill and Melinda Gates Foundation, and it embodies the spirit of what's possible when you decide to lead from where you are. Vincent, welcome to the show, and thank you for accepting my invitation.
Thank you very much, Luria. It's my pleasure to be in your studio today.
Thank you, Vincent. So before we dive in, I assume many people doesn't know you. So how do you like to introduce yourself this day, beyond your title, your accolade, and your CV? Who are you?
Well, I'm just an ordinary Kenyan, an ordinary African man, a father of two, and somebody who is just trying to do what is possible to solve some of our most basic yet very critical problems that afflict the African population. That's how I see myself.
Okay, so you are trying to solve some of our basics yet really important problem from Africa. So
yes.
What is this for you basics health problem that we face as African, and what are you doing daily?
Let me start from the beginning on what exactly inspired my story to try to resolve some of these basic yet problems that might look quite basic, but very critical for the African populations, particularly in the health sector. When I graduated at undergraduate, when I had my undergraduate degree, one of the things that kept ringing in my mind is, why do people have worms? Why do kids have worms? Why is it that people die in their homes without going to hospital? So these are very critical questions that I was asking myself. And I got hold of one of the research work by a professor, I think it was in Canada, called Carol Blasov. Carol Blasov, a researcher, was writing on gender and tropical diseases in India, and he was highlighting the intersection of poverty, gender roles, and tropical diseases in India. And I was like, okay, that looks like something that is, that is similar. That is a similar context where I live. So from that point, I really wanted to be a researcher in the health sector, and that is where my story began. So, I started my research career in a very simple way, not as a researcher, but somebody writing online. So I would search for articles at the WHO library and write up articles online. And most of these articles were around the diseases of poverty. Look, malaria, neglected tropical diseases such as elephantiasis, bilharzia, and so on and so forth. And really asking myself, why can't we do simple investments as a country to resolve some of these simple yet very critical diseases? So I wanted to build my career around that, around solving some of those simple yet critical problems in the African population.
Thank you, Vincent. And in fact, it seems like you're on good track to doing that and solving Africa's problem, because you've helped mobilize over 200 millions for health initiatives across Africa, for maternal health to neglected diseases. And so do you think that you are happy with what you have already accomplished? Do you want to do more? And what is the next step for you? Like, what is the one project moment that you are proud for what you did?
Yeah, when I look back at my career, I think I'm proud of a number of things. First of all, is that at least I've gotten two recognitions. One of the most quoted paper over 5-year period, looking at healthcare equity and financing in Kenya and across the African continent. This is a paper that has been referred. And also the second part is that one of my publications around health equity and access to care won the Best Paper Award. So just highlights of what I'm proud of. And the second part of this, and quite closely related to these two recognitions, is that I developed financing models for universal health coverage, operationalizing universal health coverage in Kenya. And the modeling results of this work are still relevant to date and are still guiding financing policy in Kenya. And thirdly, in my career across the continent, I worked very closely with the government of Rwanda to design the non-communicable disease strategy, and which attracted immediate investments from the government and an international organization. So if I were to highlight some of the moments I'm proud of, I would highlight the things that I've done that have translated into actual action, guiding policy and changing lives where it matters the most. Thank you.
So that's inspiring. So you have papers that was the most cited paper over 5 years in a row. Wow,
yes.
That's astonishing.
Yes.
So wow. That's impressive. Congratulations on that. I can see that it has
in that line of publication.
Yeah. But it's still that's impressive. Yes. And then you have another one that won prestigious award, and you've operationalized financial model. Yeah.
Yes, operational financial models that is guiding financing policy in Kenya to date.
So for those who are not public health experts, and there are people who are just listening to us, they want to understand what they can do as career path, or what is even the problem that we have in healthcare sectors. What is it, the health financing model that you have operationalized? How is it working? And even what is public health financing? Because you are doing health economy. So what is health financing in simple terms?
So health financing in simple terms, there is a difference because people think health financing is fundraising. No, it's not fundraising, but health financing involves building institutions that help in mobilizing resources for the health sector. So we look at the financing policy. What does it say about priority areas in the health sector? We look at the budgets being allocated to the health sector. So generally, the institutions, whether it is the political institutions, the financing institutions, the policy institutions, how these work together to ensure that the health sector receives the resources that is necessary for it to function. So that is the whole story around health financing. So in more detail, we look at how the sources of revenue, where is the money coming from, how is it collected, how is it pooled on behalf of the people that is supposed to benefit from the funding, and what services are being purchased, and whether these services resonate with the population health needs. So it's around the institutions that contribute towards resourcing the health sector, and also looking at the flow of these resources within the health sector to make sure that they reach where they're needed the most.
Okay, that's interesting because, in Africa, we have a lot of issue in health. And myself, I'm a health professional. So I know that in Cameroon, it's difficult first when you're working in hospitals. You lack sometimes simple things like gloves, like reagents. So I think that is what you're talking about. What are you doing with money so that people have benefiting from efficient healthcare service, right? So what is the problem for you? What is the main problem in the healthcare system in Africa?
Maybe I'll just talk about what I think are the major issues. So when we look at the continent of Africa, it has the highest disease burden. It has the highest adult mortality rates. It has the highest. It has very poor indicators in maternal mortality, neonatal mortality, child mortality. So this is where I think the problem is, because if you look at the basic indicators like maternal and child health, which actually show how a country is performing, a country's health system is performing. The basic things that we need to understand that we require accurate data, because without data, we can't make informed decision on how to control and prevent diseases. So the first thing that Africa needs to get right is accurate, integrated data, so that we can get right what is the required level of investments in the health sector, be able to have proper disease surveillance, and take appropriate measures to control and prevent diseases. A good example is, when the main drivers of maternal mortality in the African continent is like obstetric hemorrhage, hypertensive disorders, infections, because, such as HIV/AIDS, malaria, TB, unsafe abortions, obstructed labor, and poor nutrition. So if we know what drives these issues, what is the right level of investment to control them? What is the required capacity to control? So we need data to be able to make a decision around how best to respond to these to the causes of this to these problem areas. The second point is on poor access to care, and I'm particularly referring to emergency care, where pregnant mothers are concerned, but also distance to facilities, a major problem within the African context, where people have to walk in excess of 5 kilometers to access primary care, not just hospital care, but primary care services. So this is a deterrent for many people to access care. Imagine getting a pregnant woman who is supposed to deliver 10 kilometers away. This person would either deliver on the road or at home. And the delivering at home or on the road means that they lack access to safe delivery at health facilities. And these are also exacerbated by cultural barriers that hinder things like spacing children, family planning, for example, and even seeking formal care in health facilities. So there are a lot of problems that look simple, but have far-reaching consequences, especially to our mothers and children. And these have been made worse by poverty. The poverty levels are high, and if you consider poverty and poor or inadequate investments in the health sector. So if we have inadequate investments in the health sector, the population itself cannot afford the services, then you are making, that is a very bad concoction, leading to high maternal mortality and child deaths, and disease outbreaks. Let me just clarify that. So, if the population is poor, it means they need subsidies to access care. And if that subsidy is not coming, it means that these people, the African population, cannot seek medical services when they need them. So you get people dying of very simple yet very preventable conditions and diseases: malaria, HIV, TB, diarrhea, and so on and so forth. So without adequate investments in the health sector and the population remaining poor, then these deaths cannot be avoided. They will continue to rise. Although a number of countries on the continent have made significant gains in terms of reversing maternal deaths and child deaths by getting policies right and also increasing their investments in the health sector. These have translated into better economic gains across the continent. So it's important that other African countries get to understand the best case examples of, from fellow countries that have succeeded in reducing maternal child health deaths, in reducing HIV infection rates, in reducing diarrhea among children, and so on. If we look, if you look deeply into the funding of the health sector in Africa, you see that there is still unacceptable levels of out-of-pocket spending. So when we say out-of-pocket spending, it means that people have to pay from their pockets to receive care. So what does that mean if somebody cannot pay, does not have ready money in their pocket? So first, if they cannot pay, they cannot receive care. And if they don't have ready money in the pocket, yet they have to seek care, they would either go into their savings to get this money or sell an asset, one of their assets. It could be a cow, it could be land, it could be something that protects them from poverty. So once they go that line, it means that out-of-pocket spending continues to exacerbate poverty on the continent. So we are talking about many countries still paying in excess of 40% of the total health expenditure out of pocket. So in other words, many countries still rely on households to pay to fund their health systems. So that means that there is a higher likelihood of such kind of payment driving people into poverty. And also a measure of a poor performing health system is on per capita health spending, that is health spending per person. So in at least 22 countries on the continent, the per capita health spending is still below $44 per year. In other words, if you consider health money per person for accessing healthcare, each person can only afford, each person is allocated just $44 in a year to access health services. And this is not enough because according to the WHO estimates, at least each person should be allocated at least $86 per year to access care. In the African estimate, in the WHO Africa region, the estimates put these amounts at I think $246, if I'm not wrong. It's around there, $246 per person. But yet, most of our countries on the continent are at less than $44. So you could say that in terms of funding health sector to a point where the most essential services will be available to the population, we are still very far behind. And I could link this to a lack of commitment among the African leadership in seeing real changes on the continent. So how do I qualify that as a lack of commitment on the African leadership to see real changes on the continent? First, there are a lot of commitments that have been made, not just by the African Union, but also by individual countries towards the health sector. The commitments to increase funding for the health sector, reaching, what is called the Abuja target, at least 15% of the budget being allocated to the health sector. This is something that just a few countries have realized. I'm not a big advocate of the Abuja Declaration, but the reason why Abuja Declaration came into being was that the health sector was very poorly resourced, and something had to be done to push countries to increase their investments in the health sector. Beyond that, there was no evidence that informed the at least 15% of the Abuja target. And I think that this is something that also needs to be revisited and replaced, because even countries that have achieved the Abuja target, or at one point achieved the Abuja target, including Chad, countries such as Chad, there was no significant change in health outcomes. And I think that the continent needs to move on from Abuja target and consider more evidence-based, more ambitious targets to increase funding to the health sector. The other point is just corruption. I mean, you see that, there are very many stories of drugs coming into hospitals on day 1 and day 2, day 3, they are all gone. And it doesn't matter whether poor children are coming to hospital and lacking drugs because they've been stolen. I mean, that is not just stealing, that is killing. And I think those unethical behaviors needs to be stopped across the continent. There are also countries that lose a lot of money on corruption, when these can easily be, if we can increase our own fiscal discipline and efficiency, then we do have quite a lot of money to invest in the health sector. So it's not lack of money. It is just an issue of efficiency, being more ambitious, and fiscal discipline to be able to provide the basic health services to the African population, and change the narrative of a continent bogged down by disease and poverty by just getting the right decisions and doing the right things where they matter the most. Thank you.
C'est quelque chose que je peux implémenter. Si tu ne sais pas comment faire, je te laisse le lien de Elite Chercheurs Accélérateur, qui est le programme qu'on a eu à faire pour expliquer aux chercheurs comme toi comment faire déjà pour écrire de manière scientifique, c'est-à-dire développer les skills pour publier dans des revues impact facteur élevé, développer la mindset, les grandes writing skills pour gagner les financements via les bailleurs de fonds. Et enfin, on te donne aussi dans ce Elite Chercheurs Accélérateur une base de données de plus de 100 bailleurs de fonds actifs avec les appels d'offres déjà définis, de dates précises. On te donne une base de données de plus de 130 projets financiers dans le monde des meilleurs bailleurs de fonds. Et enfin, tu as également d'autres outils, des templates qui te permettent de comprendre comment nurture les conversations et les collaborateurs. Parce que beaucoup de chercheurs m'ont dit ouais, tout ça c'est bien ce que tu me dis, mais en fait, on n'a pas de collaborateurs. Et ben dans le English Research Accelerator, on te donne des scripts pour te permettre de communiquer avec les collaborateurs, pour te dire comment écrire des messages à ces collaborateurs-là.
Thank you so much, Vincent. I see that I touch a pain point for you. That's something that is burning in you. And you feel the pain, you feel the loss. And I would like to come back to what you say, out-of-pocket spending. And if somebody cannot pay, what would happen? That is something that I've realized, I think, 4 years ago. My son, I had one son who was sick very early in the morning. He was crying ear, so I guess it was otitis. So instead of going to the hospital, instead of going to work, I decided to go to the pediatrician. So I was carrying my elder one who was sick. He was 18 months at that time to the doctor. But just at the door, I was about to go when my nanny told me that the second one has just had a small diarrhea. So that was just one time. But instead of going, I said, maybe I should just go with this one also to the pediatrician because he was around 6 months old. I said, let us go and do the checkup for both and see. And we went to the hospital, to the pediatrician. It was one of the best pediatricians in the city, in Yaoundé, very far from home, like 25 kilometers, because I wanted the best care for my son. And I had money to pay. So I went to the far one. I could afford the thing. It was really expensive. I said, let me go where the doctors has a big mindset and can really assess my kid properly. And I went there. She confirmed the otitis for the first one. And she asked me, why are you coming for the second one? I said, I had one diarrhea this morning. She said, but what's hers? Nothing. He had one diarrhea this morning. She just stared at me like, how can you come and spend? Like, I could feel in her mind that how can you come spending money for one single diarrhea? Because it could have spent that he has like tooth growing. I don't know. But because I paid, she started examining my son and she said, I can't feel that he's sick. He's eating well, he has normal cells, but for the sake of your mind, for your peace of mind, and for my peace of mind myself, let's just do a small checkup. She just prescribed blood count, urine test, and I don't know, what's malaria testing also. We went to the lab directly because, again, I had money to pay for this lab testing. I traveled to the biggest lab I knew. I did all the testing again. It happens that this small one that was 6 months old had a pyelonephritis. So the urine testing was positive. She asked for urine culture directly because he had 10,000 leukocytes in the urine at the point we did the testing. But he looks healthy when I was looking at him. He looked fine. But from the test we did really early, he had a pyelonephritis, he had malaria, and the same day, she had the chance to prescribe him drugs. That again, I had money to pay it at that time because I finished my money for this thing, but I was still paying with my own money. We did that everything. We did 1 day. He had the drugs, everything. We did 1 day, and we had the result of the lab of the culture within 2 days. And by chance, this time there were no resistance with the bacteria he had. That was E. coli. And the baby was safe because of the small whistle of my nanny, because I had money all the time to have this all access to care. And myself, I start thinking now, what is happening for those who doesn't have money like I had now? What would have happened to my son if I didn't have that money at that time for the highest care, to go for all these places? I said, no, people are dying. really, people are really dying in my country and my continent. So that's how I want to come back to this point that you have mentioned that is also affecting me. And I know that it's affecting many, many people. And I think it is the point for, like you said, change the narrative of Africa. You've mentioned a lot of things about the problem that you have identified with your whole career. Now, what are the solutions, at least for having this universal health coverage that we come to the hospital, we don't have to pay for our own money and we can have care. What are the solutions for you?
So we need equitable health systems. I mean, we say that's the solution. So the question is, how do you get to that solution? So as I had said, that every country, whether it's classified low income, high income, middle income, every country has the capacity to provide some form of universal healthcare to its citizens, but at least to those who cannot afford the basic healthcare needs when they need them. Every country has that capacity. And universal health coverage, I would say, is the greatest equalizer when it comes to seeking healthcare. The point is, how effective is universal healthcare and who is funding universal healthcare? So a lot of countries have, I would say a good number of countries across the continent have developed their systems to provide some form of universal healthcare. So when I say some form of universal healthcare, it is it's a matter of priority. So a country looks at its budget capacity. I mean, what can we afford as a country? So you can come with a list of all the services that you would need, that the population would need. And then you say, okay, this is how much all these services would cost. But what we can afford, the services probably will cost $200 million. We say, no, out of this 200 million, based on what we see, we can afford just 100 million. Now, if it's 100 million that you can afford, you have to reprioritize the services that you're going to offer. So who needs what services? Who should be covered? Again, prioritization. These are the priority services. Who should be covered? We cover the most vulnerable first. So we look at people who are unemployed, people working in the informal sector, mothers, adolescents. So you look at vulnerable populations, including people who can be classified as poor, no income, no assets. So these are the people that you first target with the basic health services that a country can afford. The other question is, where would the money come from? If we're going to, if this is what we can afford, and the people we should prioritize are these, where will the money come from? So the money can come from government taxes that the government collects. The money can come from premium payments. I mean, people need to contribute to financing universal health coverage. It's never free. And actually, those are the two main sources of funding. And also, if you look at the critical role that the private sector plays. So when we have to design an effective universal, not just universal health coverage by name, but an effective universal health coverage where services are prioritized, the population to be covered has been identified and the numbers are known, services have been quantified and prioritized, costed, and population being targeted is aware of their entitlements, that if I go to a health facility, I will get these services. And these are the services that I should demand for. And then we are having a situation where, people are directly linked to services that they need. The other critical point in an effective universal health coverage is services have been costed, budgets allocated, and so on and so forth. Are these services available at the point of care? So service availability, the population is empowered to know what they're entitled to, they know what their entitlements. Then we have a system that actually functions, a system that is funded and linked services being purchased to the population health needs. So that's a functional universal health coverage. One of the biggest complaints that I come when I talk to policymakers, and I think I've tried my best to change this myth, is that we don't have adequate fiscal space because we don't have adequate fiscal space to fund universal health coverage. And that is the point I first made. It's not it's not about we don't have resources to fund UHC. It is what aspects of UHC you can fund and which are the priority populations. So when the question, or rather the complaint about fiscal space comes up, I usually say that, it is how we also design our revenue collection for the health sector, because there are quite a number of ways that the fiscal space for the health sector can be improved. And one of my works, or rather some of the works that I've done, is to estimate how much, for example, a country such as Kenya can generate from the informal sector, where incomes are difficult to identify, through various indirect taxation measures targeting particular groups. It is possible to generate additional revenue from the informal sector. And also the design of a system of a universal health coverage is very important. So when I mention design, I'm not talking about systems as such that this should be social health insurance and so on and so forth. One of the biggest debates I've had in my career is that the governments don't have fiscal space, so every other government in the African continent must have a social health insurance scheme where populations contribute to a scheme. Problem with that is that where populations are mostly informal, enforcing that contribution is difficult. So my argument has been that in such circumstances, and I'm talking about virtually every African country, where informality is like 70, 90% of the population. So you cannot collect revenue from these people unless there are better ways to enforce it, which I'm yet to identify. So the best option for me, and I would also raise, just so that I don't forget, the best option for me, and this has been, I've proposed this in every forum I've attended, is that the government takes more responsibility in collecting revenues and budgeting for the health needs of the people, of the population in the informal sector. The people that are formally employed, both in the public and the private sector, can afford to contribute to a scheme to take care of their healthcare needs. This is the system that Thailand effectively employed to get to an effective universal health coverage that we have in that country. Exactly what I'm saying. Other countries such as Costa Rica, what they did, and I think this can also be an effective way to get to an effective universal health coverage, is that if you are not paying, if you're not contributing a premium to a health scheme, like what we have in Kenya, everybody needs to contribute a premium to a health scheme. If you're not contributing a premium and you're not exempted, because there are people who are too poor to pay, if you're not contributing a premium and you're not exempted from contributing, then you meet the full cost of healthcare. What I mean is, if now I cannot afford to pay for healthcare and I go to a government facility, let me rephrase that. If I go to a government facility now, I will not pay the doctor because the doctor is subsidized by the government. So already his salary is taken care of by the government. So I will not pay this. I would probably pay for consultation fee, which is like a tenth of $1 consultation fee. And I get the other services. So what Costa Rica did was to reverse that if you're not exempted and you're not contributing, if you go to a facility, government facility, the doctor is not subsidized, any other thing is not subsidized. So you have to pay the full cost. And that encouraged people to enroll into health insurance schemes. And that is how Costa Rica has been quite successful. I don't know whether that system has changed now, but it was quite successful in driving people to contribute to a social health insurance scheme. But the most effective way is the Thailand way, that government takes more responsibility towards people who are not formally employed. Yeah. I don't know whether, I think I've answered that question now.
Yeah. I want to pause there first, because you just opened something that I didn't understood myself very well about the universal health coverage. You clearly state that even though it is universal health coverage, we can decide which part of it we prioritize first, which population benefit from these services first. Because in my mind, it was like, and I assume for many people who are listening to us, it's like, when you say universal health coverage is the whole population of the whole country and everyone can go in the hospital and then no one is safe and then you have issue and then the country is crashing and collapsing. So, but you say that no, it's not that. It is that, yes, but the country can decide to start from the priority people, the most vulnerable people, as far as they can afford, and try to find a way to fund for the services to be implemented for these people first, and then build on that to go up to another level, till the whole country is supported. Am I correct?
Yeah, exactly. Great. So in an ideal situation, universal health coverage means comprehensive health services for everybody. Well, most countries can't afford that. In other countries, it's just the basic, the essential health needs that are universal. For example, if it is primary care is universal. And primary care at a public health facility, that means they are targeting the poor and low-income groups. These are the people that mostly attend government primary healthcare facilities in the African continent. So we have to, given our economic situation, our budgetary capacity, we have to make a decision who our priority populations are, people we want to cover, the services that we can afford to provide to them, and where they are going to receive these services. It's neither in the private, you can decide whether it's GP, private sector, or purely public sector.
Okay. Yeah. Thank you so much for this clarification. I think this is a very important point, and you also discuss about how the financing system should work, like you've mentioned that it should be maybe by tax, that the government should have taxes where they take money from the people who are working, and like in the formal sectors, privately or in public sectors, and almost also maybe in industry or other company where they're collecting taxes properly and allocating the tax or part of the taxing to the healthcare system, which is not yet done in Africa. Am I correct?
No. I mean, I would say, okay, let me just clarify that because government doesn't have money. Government takes money from people and from companies and from natural resources. That's where the government gets money. It doesn't belong to the government. That money belongs to the people. So when a government wants to fund healthcare, call it free healthcare for the people, it collects taxes from the very people and use this tax to fund these services. But it's not just tax from people alone. The government also taxes companies, what we call the corporate tax.
Corporate tax, yeah.
And it also taxes companies exploring for natural resources. So all these sources of revenue for the government, this revenue should be directed towards provision of services to the population, and health is one of those critical services. What other governments have done, and what other governments or propose to do, is what is called earmarking. So they say the health sector is not well funded. So what you're going to do is that out of 16% of value added tax, we are going to add 2% on top. So that makes VAT revenues 2% higher. So what that means, and then this 2% on value addition, on the value added tax, is earmarked for the health sector.
Okay.
The other ways they do it is that they target companies, corporates, and say, on these profits you're making, you're going to contribute at least 1% of your profits to the health, to provide healthcare need, contribute it to the health sector, to provide, to help fund universal health coverage. That is making health services equitable for the entire populations. So there's that level of earmarking, but also active, direct, and indirect taxation to get health services available to the population.
Okay, so these are the solutions that you're proposing for Africa now.
Yeah, these solutions are there. The question is, how do we go about them? And a few brave countries have put in these measures. But again, universal health coverage in itself raises a lot of conflict between the private and the public sector, because in countries where universal health coverage is effective, the private sector is pretty small. The private health sector is quite small because services are funded publicly and they are provided in public health facilities. So the private sector remains with a very small population, largely those working in the private sector, to provide health insurance for. So there is potential of an effective universal health coverage to shrink the private health sector, and that makes the private sector very resistant to universal health coverage, but more so on how it is operationalized, because the private sector would want to provide services to the population from public funding. But the main debate there is that their services are too expensive.
Yes.
So they take more money from the public than the public hospitals.
Yes.
Yeah.
Okay.
Yeah.
So thank you for clarifying. I'm not going to move back to your career. So you are a brilliant African researcher. You could have fly to another country like in USA or in UK, but you decided to continue and pursue and live in Africa, in Kenya. Why?
Yeah.
What drives this decision?
I was actually offered a very good job in South Africa. I don't want to mention the university. That was, I think it was 2014. So I was offered a position, and I consulted. I mean, there are two things that make you leave or not. To me, there were two things. It wasn't money, because I was it's a very clear career path, very good salary. But if I took that job, it was going to affect my wife's career, because at that point, South Africans were not employing foreigners, though I was offered a position there at one of the universities because of my skills. But my wife was going to sit at home. So that was the first consideration. I needed her career to grow. And she just got a job. So I was like, okay, I'll pass this one so that you can, so that your career can also flourish. And so that was the first consideration. The second one was that based on that, I argued that, well, if I were to solve some of these problems that I saw when I was young, when I was younger, problems around, poverty, tropical disease, gender issues, if I were going to solve some of these problems basically around access to care, if I needed to solve these problems, I needed to provide that proximate leadership that required to, offer those tangible solutions. And where do I get that proximate leadership? By staying where the problems are. So money was not a motivation, but a motivation to have greater social impact on the people, on the population. And that was why I chose to stay in Kenya. And that does mean I've also been offered a position in one of America's universities. That was in 2018. And I still passed it, giving around the same issues.
Donc, si tu ne sais pas quelles sont tes coordonnées à l'heure qu'on se parle aujourd'hui, tu ne sais pas du tout comment tu vas faire pour réussir à clarifier ta vision, je t'invite à prendre contact avec nous. D'ailleurs, pour notre recherche Reset, c'est une formation qu'on a eu à faire qui te permet de pouvoir clarifier ta vision, où tu vas, où tu pars, et une formation totalement à ton rythme. Avec cela, tu peux aussi avoir des contact sessions avec moi et mon équipe pendant toutes les semaines pour pouvoir échanger sur ta vision et clarifier ton mindset et également ta recherche vision.
But thank you for sharing that. I think it's really profound what you said. There were two considerations in mind. The first one was your family, because you didn't want to affect your wife's careers. And the second one was the impact you wanted to let in the world. And this impact for you, because it was really linked to your community. You couldn't have the same impact like being overseas and helping your community. So you decided to stay where your community is to help and serve your community. Powerful. Thank you for clarifying that. So, but many young chercheurs or scientists in Africa now don't have or may lack your passion, your determination, your drives for many reasons that, so for some of them we can understand, for others we may not appreciate. But what, in your point of view, what will it take to reverse Africa's brain drain?
Well, the first question is why do we have brain drain? We have brain drain because sometimes we don't have the opportunity to thrive. Sometimes it's just the environment itself is quite toxic, where you have all the skills required, but you still can't do your work because of very toxic social, cultural, professional environment. I'll give an example. I had a colleague, one of my classmates trained abroad, came back home and tried to get a position in the university. And for 1 year, we remained jobless. It was letter after letter after letter after letter. And then applied for a position at the University of Lancashire. Within 6 months, he was employed in the UK. He's there to date.
Wow.
So sometimes it's not that we want to go because they offer better opportunities, but we go because the professional environment in our settings are very toxic. And we don't know what to do with some of our most brilliant minds, you know. So there are a lot of things that are considered before you see somebody moving out, or training and remaining those institutions, because those institutions recognize their talent and they offer them opportunities to thrive, to grow their careers, to mentor the next gen scientists and so on. So that kind of environment, in most cases, or in many cases, is lacking in our settings. And that is why some of us choose to go and remain there. I've spoken to a number of people in the diaspora recently in Washington. I had a conversation with some of my colleagues in the diaspora, and they say that, you know, if there is an opportunity and there's an opportunity, an opportunity is offered with the right work environment, they will pack up the next day and come back home. So they have they're very much willing to stem the brain drain and come back to invest their skills in the continent.
Okay, thank you so much, Vincent. So now, you have won the prestigious Calestous Juma Fellowship. That is something that I think few people have had the chance to win it in Africa. What does it mean to you personally, and have you ever dreamed about being so high when you were younger?
I dreamed about so high when I was younger. You know, sometimes, okay, I would consider myself quite ambitious from a very young age. I had visions of what I want to be. I wanted to be a lecturer, and I am a lecturer. So I had visions of what I wanted to be, and maybe it took quite long, but yeah, it was important that I got to where I am because I had that drive and something that was instilled in me by my father. He said, you know, once you get to university, you shouldn't stop there, move to do a PhD and so on. I didn't even know what a PhD was because I was in primary school. Yeah, but then as I grew up, I was like, oh yeah, that guy said I should do something like a PhD. And then that was really a driving factor. So I'm currently, of course, under the Calestous Juma Fellowship. Really prestigious, important. I'm really grateful for this. So currently I'm leading on a research on R&D financing project. So the essence of this is to look at the status of R&D financing in the continent and strategies for domestic resource mobilization to finance R&D, to promote R&D on the continent. So I'm assessing current R&D financing landscape and the models, and then designing and advocating for models that can sustainably finance priority R&D projects on the continent. And this work is currently focused in Kenya and Rwanda. So we're looking at what priorities what R&D priorities should be funded on the continent, where should the money come from, what funding models are working, and what other models can we recommend, what collaborations we can support R&D funding in the continent. So if you look at the whole picture here, is that Africa is the least investor in R&D across the globe, and it's and to fast track, it should realize that. I don't think those conversations are ongoing. That to fast track economic growth and create jobs for this bulging youth, the continent must prioritize R&D investments, and these investments must come from local resources, their own domestic resources. That is very important. So when you say, when I got the fellowship, I mean, first of all, it's a recognition of many years of silent work that I've done in building sustainable and resilient health systems on the continent. But it also offered an opportunity to further develop my leadership skills that are designed to take on leadership roles, not just at community level, which is very critical, but also at the continental level, something that I'm already doing. So this is very important for me. Thank you.
Thank you so much. So you've said something that what you are doing is to help or give evidence to fast-track funding system for R&D, because we need more of research and development on the continent. Especially if you look at the COVID crisis, you realize that you didn't have institution creating vaccine or drug on the continent, and you feel you need to have more investment, local investment on the continent. I've heard people or other researchers saying that African scientists should move from being grantpreneur to entrepreneur. Make sure that what you are taking for grant, you create something that then give money to your own institution by means of a tools or a solution, a diagnostic solution. What do you think about this paradigm to fund?
I think that is largely from an informed position, because research is either funded through grants or internal investments. So what I mean is, if you want to do research, is a high-risk job, really, really high risk, and most of the costs are either going into paying, like over 50% of the cost is either going into paying highly qualified researchers to do the research, which might yield nothing other than what we call rival knowledge. You know, when non-rival knowledge is you've done research, you've published a paper, and the knowledge on that paper can be accessed by anybody.
Yes.
Non-rival knowledge.
Okay.
So you can do research which results in non-rival knowledge only.
Mm-hmm. Mm-hmm.
But then you can also do research.
Okay.
It means that somebody else could read it, see gaps, and develop it, and come up with a product out of it. The other point I would make is that not all investments are entrepreneurial, in the sense that entrepreneurship, in the sense that it's profit motivated. There are innovations that are social innovations that are not profit making, but they change lives. I'll give you a good example. Universal health coverage models that are changing the way health financing is conducted in the country. And when it changes the way health financing is conducted in the country, you get more resources to the population. There is more equity, more lives are changed. that is impactful innovation. I don't get a penny for it because I did some innovation. It's a social innovation that benefits everybody. But there are also innovations, they say, in the product market, where somebody does research for 10 years, 20 years, and discovers a product, maybe a drug, that can be marketed. And the company gets billions of dollars. You know, that's another innovation. Innovation, research that leads into profit-making entrepreneurship. But if you look at the whole spectrum of research, and that is why policymakers across the African continent are ignorant about research, that research consists of, as I said, risks that constitute sunk costs. There is something called the valley of death for those people who do conduct innovations in, say, product development. So you invest billions of dollars, millions, billions of dollars in research for a particular drug. At the end of it, it doesn't work. Whatever, I'm not that basic scientist, whatever molecule you are investigating and investing billions of dollars in, eventually it's not working. What has happened there? All that money is lost.
Yeah.
Consider it lost. But then there is a lot of knowledge generated in between that can be picked up and be used to, you know, further research on the same subject that can eventually come up with a new innovation that can generate profits and so on. Again, sometimes you generate these profits. You come up with an innovation, it's working, but it can't be marketed because the market's not ready for it. So you have this new innovation and very hopeful, but nobody's buying it, you see. So there are all those considerations. So I don't believe in something called grantpreneurs to entrepreneurs. No, a lot of research is funded through grants, either from the government or the private sector. Yeah.
Okay, thank you for clarifying. So what does it mean if you don't find a sustainable way for R&D funding?
I wouldn't say we don't find a sustainable way for R&D funding. What we are talking about in the African continent is that R&D is dependent on external funding. That there is very little that our private sector and our governments are putting in to support R&D. So that is the basic point. So if it is dependent on external funding, like 80% dependent on external funding, it means that we cannot put forward our priorities because the funder has their own priorities. That is why they are coming to Africa. Two, we don't have ownership to drive the research projects that are going. We don't have ownership of the research because we are not funding it. And should those even where we have ownership and still having it externally funded, what happens if these funds are cut? For example, research projects that were being driven by USAID, they stopped. So that's why we're saying relying on external funding for R&D is totally unsustainable. And if we are going to leave investments in the lives of our people, we're going to leave it to external forces to direct investments in the lives of our people, and that is not a policy. That's an alibi to a lack of one, as I would quote Donald Kibaruka. So what we're saying is that external reliance reliance on external funding for R&D is not sustainable for the continent. The continent needs to come up with its own strategic, sustainable initiatives that will support priority R&D projects on the continent with or without external support. That is very important.
Okay, good. So now, what were you going to say to your younger self? If assuming, I don't know if you were, I don't know how determined you were or clear you were on your path, but assuming someone here now is like you were, and thinking about his future and how he can solve the problem he's seeing today in his community, what are you telling to this younger boy or young girl?
A younger me then, 21, I don't know how many years ago, when I was 21, I didn't have the clarity of what I want to be compared to a 21-year-old at this time. At this time, most 10-year-olds, 15-year-olds, 18-year-olds, they already know what their interests are, and they want to be what they want to be. They work towards that. So what I would advise me at this time, and I'm 21, is that you're never far from success. You're actually there on the path to success. And realize that you need to surround yourself with the right mentors, well, the right mentors. So you get the right mentorship in your career line. Surround yourself with people who are already practicing the profession that you want to be, or whatever career it is. You get to know these people as early as possible to get guidance from them, but you also need to have a goal. And when you have a goal, a clear goal, this is where I'm going, and these are the people who can help me, then you need to keep at it, work at it, have that passionate focus and the patience to get things done. There will be failures, but these are not, but failure is just part of learning. It's not something that should bring you down. It is you learn from your failures, you pick yourself up and move forward.
That's so powerful. So you say you are never far from success. You are actually
Never. I mean,
there on the path.
Nobody is ever. Yeah, you're right there.
You're right
So
there.
it's just about who are your mentors? What is your goal? Who are your mentors? And are you willing to put in the work?
Yeah. Are you committed to it? Yeah.
Yes. You have the patience, and can you pick up yourself when you fail? Those are the key issues there.
Okay. So you say also failure is also part of the learning. What was one point in your journey where you almost gave up, and what helped you going?
In my research career, yes. I think I had one incident that nearly changed my thinking about research. So towards the end of my PhD, I had a brilliant idea. Actually, I was just expanding on my PhD work to apply for a grant. And, if you're working in a very unethical environment, a lot of things happen. So as I was trying to get new ideas around my PhD, develop new ideas around my PhD to apply for a grant, I realized one of my colleagues had stolen my idea, picked from my PhD and wrote a grant on it.
Oh.
And I'm like, I don't want to be party to such kind of that. I think I had very strong professional ethics, and I was too trusting to realize that people are quite dirty. Some people are quite dirty. So when this got to me and I complained to one of my mentors, he acknowledged this is wrong, but he said, no, let's move on. things happen. You use the word, the research world is quite corrupt and all that, which I don't believe in. But I thought that was something that was quite unethical and had me thinking that, no, I don't want to be part of this. I need to go do something else. Yeah, but this mentor changed my mind, and here I am.
Thank you. Thank you for sharing that. So
Yeah.
before closing the podcast, the interview today, we end every conversation with this ritual, a moment to rise, or a moment where you share one single thing. We have a question that we share, and you discover the question now. You just have to answer with one sentence. All right? Are you ready?
Oh,
One sentence.
sure.
Okay. So in one sentence, what is the thing that the world should remember from you?
Well, the one thing that the world should remember about me, they could write on my epitaph, is that I tried my best to solve some of the most pertinent problems around access to healthcare on the African continent.
You try your best to solve African problem on the continent.
As healthcare, to solve some of the pertinent problems around access to healthcare on the continent.
Thank you. Thank you so
Of course,
much.
that's what I do.
Well, yeah. Thank you so much, Vincent, for this conversation, for taking your time.
Yeah.
And if this conversation inspire you, go share it. And if it challenge you, reflect on it. And if it move you, start now, right where you are. Like Vincent just mentioned, you are right on the path. Just act on it. And that's what we do at Dream for Africa Stories, because we believe anyone can thrive, starting from anywhere. Thank you so much again, Vincent, for this time, and I hope I will meet you again next time. Thank you.
Thank you for your time. Thank you for inviting me.
Thank you. Bye-bye.
Bye.